Okay, let's dive into a really specific, crucial document today. It's Dr. Gregory Weir's post-angioplasty protocol.
hmm
We're not just reading it, we want to unpack it,
Yep.
really understand the key instructions, the actions for patient care right after an angioplasty.
Yeah, those first few hours and the day after are critical.
Exactly. Think of it like peeling back the layers on this medical checklist to see why each step is there.
Absolutely. And this protocol, it's a great example of how, specific data points, they drive specific actions.
Okay.
It's basically a roadmap for that immediate recovery, focusing on stability and catching any problems early. We'll look at what they measure and what those measurements trigger.
Okay, so let's start where the protocol starts. Managing blood pressure.
hmm
Right after the procedure, it focuses on MAP, mean arterial pressure.
That's right.
What's the target range they're looking for here? Why is that number so important?
Well, the protocol sets the target MAP between 70 and 100 mmHg. That range is really vital because keeping the pressure there helps prevent complications. If it's too high, you worry about bleeding at the angioplasty site.
Okay.
But if it's too low, the patient might not be getting enough blood flow to vital organs, including the heart muscle itself, obviously.
And the protocol is specific about what to do if the MAP is outside that 70 to 100 window.
Oh, very specific. It's a clear decision path.
Right.
If MAP is over 100 mmHg, the instruction is nitrosine titration.
Nitrosine titration, so carefully lowering the pressure.
Exactly. Now, if the MAP is under 70 mmHg, it says check the central venous pressure, the CVP.
So if the pressure's low, they need more data. CVP gives you that insight into fluid status, heart filling.
Precisely.
Yeah.
It helps figure out why the MAP is low.
Okay, so what does that CVP number tell them?
Well, if the CVP is low, less than 10 centimeter H2O, it suggests maybe dehydration, needs more volume. So the protocol says Ringer's bolus, 250 milliliters an hour. That's IV fluid.
Got it. Give fluids.
But if the CVP is high, over 10 centimeter H2O, while the MAP is still low, that suggests fluid probably isn't the main issue.
Right.
So then, the instruction is noradrenaline titration. That's a med to help raise blood pressure by constricting blood vessels.
Wow, that level of detail.
Well,
One number, MAP, dictates the next test, CVP, and that result dictates the specific treatment. Really structured.
it is very logical.
Okay, beyond these immediate vitals, the protocol also lists specific lab tests. From Lancet Laboratories, it notes, what's on the list for day 0, the day of the procedure?
Okay, day 0, it lists Hematocrit HCT, which is, red blood cell percentage, gives an idea about blood loss,
Mm-hmm.
and Troponin T, TROPT. That's a key marker for any heart muscle damage.
Right, troponin. And what about day 1? What tests are needed then?
Day 1 broadens things out. You've got UK urea, potassium, electrolytes, looking at kidney function balance.
Okay.
Then a full blood count, FBC. A C-reactive protein, CRP, for inflammation. Myoglobin, another early marker for muscle damage, including the heart. And importantly, repeat the TROPT from day 0.
So monitoring for bleeding, heart issues, inflammation, general stability, it covers a lot. Now, what about checks related to the procedure itself and ongoing care?
Yeah, a really critical one is the activated clotting time, or ACT. It's checked exactly 2 hours after the procedure finishes.
ACT. That tells them how thin the blood is,
Yeah,
because the heparin used during the angio.
exactly. And if that ACT is high, meaning the blood is still quite thin,
What happens then?
if the ACT is over 140 seconds, the protocol says contact Dr. Weir about protamine.
Protamine, the heparin reversal agent.
Correct. Helps the blood clot more normally if it's too thin.
Okay, that makes sense.
Okay.
And this ACT number, along with the MAP, that's also key for deciding when to remove the sheath, right? The one inserted during the procedure.
Absolutely crucial. And the protocol is super precise here. Sheath removal is only allowed if 2 conditions are met.
Okay.
MAP has to be less than 100 mmHg, and the ACT has to be less than 140 seconds.
Both have to be true.
Both. If they are, then remove the sheath, following the direction on a diagram mentioned in the source. It really highlights you need pressure controlled and clotting near normal before removal. Minimizes bleeding risk.
That dual condition.
Yeah.
Yeah, that's risk management built right in.
Hmm.
What other general care things does it mention?
Let's see. Providing an O2 mask, supplemental oxygen, elevating the limb if there's swelling, edema. Maintaining the hematocrit, the HECT we mentioned, above 30%.
Right, monitoring blood levels.
Yeah. And if a CVP line was put in earlier, they need a chest x-ray to confirm it's placed correctly.
Clear, practical steps. Okay, finally, activity and diet. What are the instructions post-procedure? Day 0 versus day 1.
Right. Day 0, strict bed rest. probably to minimize any issues at the access site like bleeding.
Makes sense. But can they eat or drink?
Yes, the protocol explicitly says the patient may eat and drink.
Okay. And day 1, things change.
Yeah, day 1 is mobilize, get the patient out of bed, start moving. That's a big step in recovery.
Right. Assuming all the checks and labs from day 1 look okay.
Presumably, yeah. When stability is looking good. So when you look at this whole protocol, you really see how every single instruction, from managing blood pressure, checking ACT, even saying when someone can get out of bed, it's all tied back to specific measurements, specific clinical signs. It's just a really clear example of data-driven care right there in black and white.
It really is. It's not just a list of suggestions. It's like precise triggers for precise actions, all aimed at keeping the patient safe, getting them through that initial recovery smoothly.
Exactly.
So, thinking about this detailed roadmap from Dr. Weir's protocol, what strikes you, the listener, about this level of precision needed right after an angioplasty? How these specific numbers, MAP reading and ACT value, they aren't just info, are they? They're direct commands for what happens next. Something to think about.